My job, as Sean said, is to introduce you to the Lucid story, the how and why we got started and how we've built what we have and where we're going. So let me just start with some numbers. Let's start with the number 40. Before we're done for the day today, approximately 40 Americans will receive some tragic news, what is effectively a near-death sentence. And their stories will generally be pretty similar. Some middle age, maybe a bit elderly, 5, maybe 10, 20 years of chronic heartburn that's well managed on over-the-counter medications. Otherwise pretty healthy and active, except maybe a bit of obesity, but a lot of us have that. These 40 Americans woke up very nervous this morning about their upper endoscopy procedure that was scheduled for today. And this is scheduled to evaluate some recent weight loss, maybe some swallowing problems and or some fatigue. Then, sort of like a punch in the gut, the tragic news from the endoscopist, somebody like the two doctors we have here today, came back and reported esophageal cancer. The prognosis, terrible, really, a near-death sentence. Within 1 year of today, 10 of them will be dead. After 5 years, only 8 approximately will still be alive. So according to the American Cancer Society, this year, 2023, about 21,000 people got this similar news, this tragic news. So what if cancer could be prevented? You might think that's sort of an odd thing to say. You know, we bat the word cancer prevention around a lot. We use it quite liberally. We sort of use it interchangeably with early cancer detection. But you know, early cancer detection programs like mammography for breast cancer, low-dose CT scanning for lung cancer, even PSA checks for prostate cancer, they've successfully prevented deaths from these cancers. And maybe PSA is a bit controversial on that, but none of these are cancer prevention, right? You get cancer and you pick it up early and it has an impact on your outcomes. So, despite decades of scientific research and technological development, there are really only 2 cancers that we can truly prevent through early pre-cancer detection. And as you'll hear in a bit, our Vice Chairman, Stan Lapid, has played a central role in both of these. Pap testing does prevent cervical cancer, not just cervical cancer deaths. Colonoscopy prevents colon cancer. We pick up polyps, and stool DNA testing can pick up about half of the more advanced precancers. All 5 of these programs have been operational for decades. We know that they do save lives, but there really haven't been no new early cancer detection programs in ages, really. Cologuard came around in the early 2000s, but other than that, these are really relics of the 80s and 90s. There really actually are 3 high-value targets for such new initiatives for early cancer detection or cancer prevention: pancreatic cancer, esophageal cancer, and liver cancer. I'll call these the deadly 3. I was actually surprised about this statistic. I told Brian de Guzman about this before we started. If you add up these 3, the 3 cancers with the highest mortality rates, you can see there are 13%, 22%, and 22% survival at 5 years. So this very similar prognosis to what we have with esophageal cancer. The total number of deaths from these 3 cancers is actually higher than the number of deaths from breast cancer and colon cancer in a given year. That's because we actually have appropriate early detection tools for those cancers and we don't for these. So even though we think about these maybe as less common and they're not really, we don't hear about them as much because we don't actually have anything historically we've been able to do. Patients get diagnosed and then 80%, 90% of them die within 5 years. The other similar statistics amongst these 3, among the deadly 3 here, is that picking them up in the early stage 1 or stage 2, doesn't really accomplish a whole lot. So you can see here, less than 50% will survive even if they're picked up at stage 1. So the notion that you can actually have an impact on cancer deaths from early cancer detection doesn't apply here. It applies for breast, it applies for colon. If you pick up somebody in stage 1 breast cancer or colon cancer, they actually do have very high survival rates from that. The treatments are appropriate, but not for these 3. So in order to have an impact on survival, we need to prevent cancer for these three. And the only way you can prevent cancer, given that if you pick it up at stage 1, that's not really a victory, is to have pre-cancer detection. Although there's active research in early detection of pancreatic cancer, there are a few companies out there that are working on that. I'm sure some of the analysts in the room have seen them, as well as liver cancer. There are a variety of liver cancer programs for early detection of liver cancer. I'm not aware of any science or work on detection of precancer for liver or pancreas. So as you saw from the previous, or you see from the slide, even if we have a pancreatic test that can pick up pancreatic cancer or liver cancer, we're not going to really have much of an impact because half the patients are going to be dead, even if you pick them up at stage 1. So thanks to what I really consider one of the biggest scientific breakthroughs in cancer prevention in recent memory, esophageal precancer can now be detected. That means that esophageal cancer actually can be prevented. And not to be overly dramatic here, but this is a big deal. I mean, we don't talk about this enough, that what we historically do is early cancer detection. You pick it up at stage 1, you get your chemo, you get your surgery. If you're fortunate to have one of the cancers where that's applicable, you have a 90% chance of surviving in 5 years. But we can do that for esophageal cancer. Those 20,000 patients who get diagnosed a year, the 40 people who are going to be diagnosed with this near-death sentence today, we can prevent it in them. And that's our mission. That's why Lucid exists. So let's talk a little bit about our roots. Lucid was founded in 2018 to commercialize a scientific and technological breakthrough that was developed by a brilliant team of scientists and physicians here, led by one of the leading cancer geneticists, Dr. Sandy Markowitz, at Case Western Reserve University, Kyle's alma mater, just remember. Their work was funded by the National Cancer Institute, and their collaborators included many of the world's leading experts on esophageal disease from the Mayo Clinic. You can see co-authors on this paper include people from the Mayo Clinic, Johns Hopkins, UNC. And this Sentinel 2018 manuscript, which I'll talk about in a little more detail in my latter talk this morning, reported really outstanding results from a multi-center study on this groundbreaking molecular diagnostic test to detect even the earliest stage of esophageal precancer on cells collected non-endoscopically in a minimally invasive way in a physician's office. Again, not to be overly dramatic, but no molecular diagnostic test of any type has been able to detect any type of precancer at this early stage in any reports that I'm aware of. And this is the test that's now commercialized as EsoGuard, and we've done 10 to 15,000 of these over the last few years. So who are we today? Over the past 5 years, Lucid has made enormous progress on all fronts to bring us to where we are today. I believe we're a strong company. We have a solid foundation with real potential to be a great company with high values in the future. We have a high margin asset with a massive market opportunity in EsoGuard. As Sean will talk about in quite a bit more detail, we have a well-honed, multifaceted commercial strategy. We have a world-class leadership team, many of whom are here today, and you'll meet later during the fireside chats, and a world-class board. You'll hear from our vice chairman in a bit. We have an operationally excellent multidisciplinary field and laboratory team that we're really proud of. And we have a real deep bench of committed and passionate physician ambassadors who you will see, who will be talking to us later today as well. Let's talk a little bit about the market opportunity. A couple of additional numbers, 30 million. There are 30 million patients in this country who are at risk for esophageal precancer and are already recommended by guidelines for precancer testing. $1,938, actually should be, and 1 cent. That's our Medicare payment rate. So we have an official rate. We've had that since 2021, and that price, just around $2,000 or a hair less than that, has actually held up quite well in our engagements with private payers. So that's a approximately $60 billion market, totally addressable market opportunity, which we believe is real. And then finally, we have a 90% gross margin, and I'll talk about, and Dennis will talk in a bit more detail on how that's held up.
Lishan,
Yeah, please.
30 million would be, 1
Yeah, Sean's going to talk a bit more about the risk profile, but I'm glad you, Anthony, you reminded me to point that out. That's actually the most conservative number, right? So the guidelines, there's the ACG guidelines, there's the AGA guidelines. They have some differences within them. Some are a little bit more liberal, some are more conservative. This is based on the American College of Gastroenterology guidelines with only limited to those over 50. So it's a 50-year-old who has 2 other risk factors and heartburn. That's how many people there are. There are 30 million of them. And that number actually doubled with the last update of the guidelines, because the guidelines used to equivocate about women, saying maybe women have as much risk of having precancer, but they have a lower risk of progressing to cancer. So the guidelines had previously sort of equivocated about that. They don't anymore. So if you're a woman with heartburn and you have 3 other risk factors, obesity, smoking, family history, et cetera, then you qualify to be tested. So that's a real number, simple as that. Thanks. Okay, so I'm going to move on here. What have we done and what's there left to do? So it's a little busy here, but we've done a lot. So I'll go through them individually. On the commercial side, our sales and marketing process, as Sean will show you, is locked down. We know exactly how to talk to physicians. We know how to secure adoption. We know how to drive test volume. We're driving test volume with an increasing productivity rate by our sales team. And there's no mystery about that anymore. And Sean will explain to you this quite sophisticated approach that our sales team takes. We have a lockdown patient acquisition strategy, and it's been designed and it's been implemented. It's multi-pronged, as you'll see. You'll see a bunch of acronyms, alphabet soup, Lucid Test Centers, satellite Lucid Test Centers, mobile Lucid Test Centers, check your food tube events. All of that is really humming and operating like a well-oiled machine right now. Our strategy with regard to how do we get these cells so they can be tested, that's also been worked out. It's optimized. We use our own clinicians, our own nurse practitioners or device administrators as much as possible. We have rigorous ways we train them and confirm that we monitor them to make sure they have good outcomes. We have metrics to track them, and we have now a 99% success rate at getting cells and getting sufficient of them completing the procedure. So that's worked out. There's no further mystery there. It's just about continuing to implement that. In the laboratory, same thing. We acquired our own CLIA-CAP laboratory about a year, coming on 2 years ago, and we successfully transferred the EsoGuard assay from the commercial lab that we had been working with. And that you'll hear from Dr. Verma, as Sean mentioned, but the performance of the EsoGuard assay and our efficiency in performing that has been optimized. We reported a 2.0 version of the assay recently that continued to improve on that. Our QNS rates, which is the quantity non-sufficient rate, so the percentage of patients who don't have enough DNA in their cell sample is now less than 5%, which is a great number. And the efficiency of the assays is improved to the point where we can reliably turn these around in less than 10 days, usually closer to 7 days. We've also been working on the gross margin, and we've optimized the assay costs, and some of the work that was done in the efficiency of the assay has yielded benefits with regard to the cost of performing the assay, as well as the cost of the device itself, of the EsoCheck cell collection device. We've moved that to a high volume manufacturer and gotten that cost down, and we're now hitting, at our current volumes, our target gross margin of 90%. 2 other buckets are clinical evidence and on reimbursement. I'll talk about this in my talk later this morning, but we've really expanded our clinical validity evidence base beyond the original paper that was published, that Sentinel paper that was published in 2018. And that data, as I'll show you, shows unprecedented detection rates for precancer, early precancer as well as precancer as a whole. As you may have seen in our press release yesterday, we finally have a solid base of clinical utility data. You don't know how happy that makes me, because we've been waiting for that for a while. So we reported on 3 peer-reviewed papers that were published in peer-reviewed journals on clinical utility, and they all met their endpoint with near perfect concordance between the performance, the result of the test, and the impact on medical decision-making by physicians. So look, we'll continue to expand our clinical evidence base, but compared to where we were 6 months, 9 months ago, we now have a real solid, substantial base of evidence, both on clinical validity and utility. I'll dive into that a little bit more later as to what those two mean. And then finally, in reimbursement, we're making progress there as well. Our revenue cycle management process and infrastructure has been upgraded, and many of you have already heard us talking about that. We're very happy. We've had dramatic improvements in how our claims are being processed through the commercial payers, and just getting paid getting allowed claims, getting those claims to actually work their way through the system and getting paid for those. So that we really have the infrastructure locked down for that as well. And our market access team, as we reported in a press release, I think about 6 weeks ago, we've strengthened our team. We have a new VP of Market Access, who you'll meet a bit later, and a VP of Employer Markets, who's actually wondering, who's back in the back of the room there, will be available for chatting as well. So all of those green items we've locked down. We're down to the last mile. Now look, this is the hardest last step. I'm not minimizing it, but all of the other elements are solidly in place. And so the two areas that we need to establish our medical policy coverage. So we're in-network. We have in-network coverage with commercial payers as well as with Medicare, to leverage our clinical utility data, which is now sort of fresh off the press, to drive medical policy coverage, including pilot programs such as coverage with evidence development, so-called CED programs and otherwise. So that's one major initiative. What are we doing now? That's what we're focused on, really, as much as anything. And the second area is direct contracting, which Sean will talk about as well. That's an alternative path where instead of going through the traditional payer pathway and getting paid by submitting a claim and getting paid on claims, we have initiated a very aggressive push into direct contracting, where we are looking to drive direct contracting with self-insured employers and entities to offer the EsoGuard test as a benefit within their health and wellness program. So that's a direct contractual relationship with self-employed entities. We've announced we had our first contract. Those patients are being tested as we speak this quarter. That'll drive revenue. And we've, as I mentioned, we've hired a new VP of Employer Markets to help really drive that business and push hard on that. Okay, so that's it. That's our last two. Those are the last two boxes, and hopefully next year we'll have this and we'll be able to turn those green as well.